Uh, Thank you, Dr. Srinivas, for giving me again the opportunity to participate in TCT India. Uh, as you know, I have been telling you and have been taking advice from you also. We started our primary PCI project that was not present in Mauritius till now, especially in the government hospitals in a 24-hour basis. So that is what I'm going to present today, 24/7 primary PCI. What has been our initial experience, because I'm the one who started to think that we should bring this on a 24/7 basis in our public hospitals, because public hospitals is a place where most of the patients are going to attend, and these are the patients who benefit from it the most because they don't have money and they can't go to the private sector. So this is where the idea came that I should start it, though we had the youngest interventional team. So you can see in the picture, this is a hospital where I work, and by the side of it, you can see, I think you all recognize Dr. Seth, Dr. Ashok Seth, who was my mentor. I was with him for 6 months to learn how to do PCI, angiography, and primary PCI especially. So I'm going to share you my experience in this year that has passed by when we started in our hospital to do primary PCI. So as we all know, according to any of the guidelines, AHA guidelines, ACC, ESC, NICE guidelines, or SKY guidelines, or any local or international guidelines, they all say only one thing. In a STEMI patients, earlier the culprit vessel is open, better it is in the immediate, short-term, and long-term outcome. In myocardial infarction, minute means cardiac muscle. So each minute that passes by is critical, because every minute one part of our myocardium is dying if the artery is kept blocked. So there are two ways, as we all know, to open the blocked artery. One is by thrombolysis, that is medical management, and the other one is PCI interventional. We are all very much aware about it, where we do angiography and angioplasty, and we try to open the artery as fast as possible. So we have 5 regional hospitals in Mauritius, and thrombolysis is still used in most of our 5 regional hospitals even now. A coronary angiography may or may not be done before discharge of the patient, and the patient, usually in most of the centers, they are put on a waiting list for coronary angiography. Then a decision is taken whether to do PTCA, CABG, or patient goes in medical treatment. And if the patient happens to be lucky and he is in a hospital where cath lab is available and is free, he may benefit from primary PCI, and that also in very selected hospitals, for example, in ours. So according to all the guidelines, we all know it's a very busy slide. We're not going to go in full detail of it, but what we know is in less than 2 hours, we should try to open our artery. And according to NICE guidelines 2020, in the first contact of the patient with the chest pain, an ECG should be done in less than 10 minutes. And in non-angiography centers, thrombolysis should be performed in the next 10 minutes to come. And in PCI-capable centers, an angioplasty should be done in the first 2 hours if patient presented to the hospital. And wire crossing should be within 90 minutes. So, and if the patient happens to be in a cath lab available center, then primary PCI is a preferred treatment, because the artery is open under vision and the chances of failure is less. And also, if we're not using a thrombolytic, then there is lesser risk of bleeding. The patient gets immediate relief of symptom as soon as the artery is opened. So now let's see how things were in our country. Before 1st September 2020, this was a date where I was appointed as the head of Department of Cardiology in the hospital where I'm working right now. Our cath lab used to be open from 9 to 16 hours. Streptokinase and then later on tenecteplase were used to thrombolyze, and the patients were sort of stabilized. Then CAG was deferred, or the patient was put on a waiting list of coronary angiography, where the patient is going to have his angiography on a later date. Then a decision was taken whether to do PCI, CABG, or the patient will require medical treatment. The cath lab used to be closed after 4 p.m. So this is what struck me, because we can't close our cath lab after 4 p.m. On a Saturday noon, and Sunday and public holidays were closed. So unfortunately, all those patients who did their MI during these periods where the cath lab was closed, they all suffered either from the complications of thrombolysis, or some of them even passed away. And in cases of failed thrombolysis, rescue PCI were preferred. Then we have 2 other centers in our country where the patients were transferred to the 2 centers, Victoria Hospital or Cardiac Center. And that also, if cath lab was available, place was available, and also it depended obviously on the mood of the doctor whether he wants to do the case or not. So some patients in so doing passed on the way before reaching the hospital, or even some of them died after coronary angiography. As we know, minute means muscle in STEMI. Precious time were lost while transporting the patients via ambulances. So this is a hospital where I work. It is situated in Port Reitz, in the center of Mauritius. It is the capital of Mauritius. And we, at Dr. G2 Hospital, we had a dedicated, young and dynamic team, and we were ready to take the challenge to start primary PCI on a 24/7 basis, so that the patients can benefit from it. So that team comprised of myself, 6 cardiologists, myself as head of department, 2 consultants, and 3 specialists. So since the past 9 years, in the beginning, streptokinase was used, then tenecteplase was used, and no primary PCI was done on any of the patients. They were mostly thrombolyzed, and then they were taken for an angiography at a later date. And on 1st September 2020, this is the first day when I joined hospital, and when I joined at 10 o'clock, we got 1 patient. So this was a challenge that presented to me right from the first day. There was a patient who presented. So this was the first time when we said, no, we are going to go ahead and we are going to do a primary PCI on this patient. So on 21st June 2021, 24/7 primary PCI was given to us by the Ministry of Health and Wellness as a pilot project of 3 months. And this is when the patient presented, 38 years old male, uncontrolled diabetes, smoker, 10 cigarettes a day, with epigastric discomfort since last night. He was having central chest pain for 1 hour. He was unable to speak. He was at his site of work. He got a malaise and suddenly he lost consciousness. When he regained consciousness, he was brought to the hospital by his colleagues. And this is what his ECG looked like. So we can very well see there are ST elevations in anterior leads. And we immediately proceeded for an angiography. And this is what was the result. So we can see the right coronary artery, which looks almost normal. And this is the left coronary artery. And we can see that the LED is completely blocked right from the middle, from here. So we proceeded and we passed a wire, it's a cyan blue, which went away very, very smoothly. We stented the patient, a direct stenting, and then this is a result that we got. The diagonal is a bit pinched, but that is quite normal. If the main artery, the LED is open, and then we have a T3 flow in the diagonal, we left it like this. And this is what his echocardiography looked like the next day. So you can see it's a very good LV. Nothing was lost in the LV, and the case was over in 15 minutes. The patient was discharged on the 3rd day. He was reviewed in 2 weeks. Patient was very much stable, without any chest pain, was leading a normal life up till now. So what are the advantages that we can get from 24/7 primary PCI? So the artery is open under vision, so chances of success is very high. Pain and ST elevation subsides as soon as the artery is opened. No thrombolytic is used, so there is no risk of bleeding complications. No risk of anaphylaxis in case streptokinase is used, as in some African countries. The ejection fraction of the patient is preserved. His personal, professional, and family life is preserved, so he is productive in all aspects. The days of hospitalization in most cases are 3 instead of 4, or at the most 4 days. The patient's professional, personal, and family life is intact. So these are main advantages of the patients. The patient has an early return to professional, personal, and family life, as damage to myocardium is less or almost nil sometimes. So what it can bring to the management system, to the hospital and the system. So there are only advantages in primary PCI. So, I'm sorry. So days of hospitalization is halved the normal course as compared to thrombolysis. So bed turnover is doubled. First, one dose of tenecteplase, at least in our country, it costs around 30,000 rupees, and a PCI may cost around 10,000 rupees. Up till now, we have done 214 cases of primary PCI in our center since 21st 6 2021. And up till now, we have saved 30,000 and 214, around 6 million rupees in our hospital budget. The thrombolysis leads to bleeding complications, which we have all avoided, like CVA, GI bleed, or sometimes it can be fatal, and all these can be avoided. So this is our where our Ministry of Health is situated. So it purchases tenecteplase for different hospitals, and the total makes to around 2,500 vials of tenecteplase. And if we multiply that figure by 30,000, it makes around 75 million rupees that can be saved per year only on tenecteplase. One cath lab, it costs around 35 million rupees. So we can install 2 labs per year in any of the hospitals just by doing primary PCI around the clock in our existing 3 cath labs. So the money saved can be used for other developments in the health sector and in the development of the hospital. What are the benefits, the advantages? I've told you. Heart failure patients post-MI will need lifelong treatment, so it adds up to an additional cost to the system in the treatment of the patient, follow-up, and the patients are going to come for pension, because in Mauritius, all the patients who have an ejection fraction of 10, 15, 20, and they are in severe heart failure, they all get pension. So this adds up to our social security expenses. And also 1/4 amount is spent during hospitalization of STEMI patient undergoing primary PCI as compared to thrombolysis that cost 4 times more. So the cost of the hospital can be, or of the procedure can be minimized by 1/4, and the hospital bed capacity is doubled. So our initial aim, in fact, when I joined the service was, at least because cath lab at our hospital was closed since its opening after normal working hours on Sundays and public holidays, many lives were lost and irreversible complications endured by patients, the family, and the system. So we thought that at least we open our cath lab for at least a rescue PCI. But then I thought that instead of asking for rescue PCI to open my cath lab, if the cath lab is going to be open, let's work on a 24/7 hour basis. So a request was made to the Ministry of Health as a pilot project to open our cath lab for primary PCI for STEMI patients around the clock. And that was approved by the Ministry of Health on 9th of June 2020. Then we started having a bit of, as it is, when we are used to a system, we don't want to change it. So there were some problems of implementation. There were problems of acceptance. We had to prepare a team and get their approval. Fortunately, our team was young, eager, dynamic, and competent, and they were willing to take the challenge. Then we started getting problems with anesthetists because we were lacking anesthetists because there is an anesthetist which covers our cath lab on a 24/7 basis. Started having a bit of issue with the radiographers, as in all hospitals we also lack radiographers. Then the place to rest, mess, payment issues, etc., like multiple problems. Then we had to convince everybody at the level of the ministry, because we had to like make them aware how this is going to bring a change, a paradigm shift in the treatment of primary in the treatment of myocardial infarction patients. So we had multiple meetings at the Ministry of Health and Wellness, and all was settled, and programs was started on 21st June 2021. So what has changed since our last meeting? Like last year, I presented in TCT also. So if a patient is coming to our ER department, the history is taken and ECG is done. And if the patient is in STEMI, aspirin, clopidogrel, or Brilinta or prasugrel is given on a stat basis, the patient is immediately shifted to the cath lab. And if we have any cases that are pending, we just stop everything and primary PCI patients goes into the cath lab. Primary PCI is done, the routine cases are stopped temporarily, and if the patient is picked up by SAMI. SAMI is our emergency system, ambulance system in our hospital, in our system, in our health system. So they call to inform us. The patient is loaded at the site, and all the procedures of casualty emergency department is bypassed by SAMI, and the patient is directly brought to our cath lab without any further delay. And this is done only at Dr. Jitu Hospital for the time being. And rescue PCI is still done in our other two centers. Our vision is every patient presenting with STEMI should benefit from primary PCI on a 24/7 hour basis. Primary PCI can be extended to all three existing centers and get one more at other two hospitals. So every citizen has a right to get the best treatment in case of STEMI, which is primary PCI. So in conclusion, I would like to say that primary PCI is the latest recommended treatment. Anywhere where we have got a cath lab, any interventional cardiologist would like to do primary PCI around the clock, because this is the only thing that saves lives, and this is the only thing that is going to benefit the patients. So primary PCI is the latest recommended treatment for STEMI cases worldwide, accredited by all renowned international guidelines since years. It has only advantages not only for the patients but to the health system and society as a whole. There should be a political and professional will to impose such decisions in the benefit of all and the system as a whole. And we managed, being the youngest team of interventional cardiologists, in less than a year to implement change, whole the cath lab staff, train new personnel, and now we are training doctors from other hospitals in Mauritius. So Mauritius has the advantage of being a small country, and any corner of it is reachable in less than 120 minutes as recommended by all international guidelines. There should be, of course, a will to do it. So
Thank you.
You can see the picture in the middle is our health minister just by my side, and on my right side is a Japanese ambassador. So our hospital, the coronary care unit of Dr. Jitu Hospital, is the only public sector to win the competition of African Kaizen Special Mention Award in 2021, organized by the Japanese authorities for the good job we are doing on 24/7 primary PCI basis. And I thank you all for your kind attention.
Thank you, sir, for an excellent work which you're doing and saving so many lives. That's what gives happiness as an interventional cardiologist. And I'm surprised by the analysis you showed that PCI is cheaper than the lytic drugs in many places. In other words, it is different. But I appreciate all your efforts and congratulate you.